are back to Triple F webinar, and myself, Dr. S. Deepa, President Scientific AVMC, will be hosting the session today. I welcome all the participants to this Forefront of Future Frontiers webinar, a medical webinar series popular by the name Triple F webinar, organized by the Scientific Society of Arpadavida Medical College, VMRF, deemed to be university in the midst of COVID pandemic. This is a medical webinar series to translate novel scientific innovations and integrate them into practice. After completing 14 theme-based series successfully, we are into series 15 with a very important theme, that is trends in medical education. Episode 95 today, and we are heading towards 100th episode. Today in episode 95 of the 14th series, we have an important topic which is incorporated into the CBME curriculum, which we all the faculty as such are aware of by the NMC, and it is nothing but the evidence-based simulation. And we have the simulation expert, Dr. Dinkar Ramanandapai, Professor of Surgery and Director Medical Simulation Center, MGMCRA, and he has also been with us part of our skill lab in upgradation of our skill lab to bringing it in the shape. We have sir has got very important role in that. Thanks to sir, and he has been with us for enlightening us on this very vital topic on simulation. Now I'd like to invite our Director Medical Research, Professor Vishnu Bhatt sir, to give the opening remarks and introduce the speaker of today. Sir, please.
Good afternoon to everybody. On behalf of the management and administration of AVMC and on all your behalf, I welcome Dr. Dinkar Pai, who was our student in JIPMER and now is a well-known uh, person in the field of skill development. He is basically a general surgeon. He has done MBBS, MD, MS from JIPMER, and he was working as a faculty in JIPMER before I think he changed his interest in skill training. At present, he is Professor of Surgery and Director of Simulation Center at Mahatma Gandhi Medical College and Research Institute in Pondicherry. He obtained his certified healthcare simulation educator certification from the Society for Simulation of Healthcare in the USA in 2016. He is a certified team master trainer for team training for a agency for healthcare research and quality in USA. He has done his FRCS from UK and later this simulation training from USA. He is a certified NHET SIM certification course of from Australia and has completed his Bristol Boston masterclass for simulation. So he has been well trained everywhere. He is president of the Pan Asian Simulation Society in Healthcare and founder secretary and life member of Singapore Society for Healthcare Stimulation. He is a life member of Malaysian Society for Simulation in Healthcare and board member for Pedistars Simulation Society in India. He is a senior editor for the International Journal of Healthcare Simulation Advances in Theory and Practice. He has been the chairperson of the Technical and Advisor Committee for Simulation of the Kerala University Health Sciences and is a visiting consultant in several colleges in India and abroad. And you must have seen him in AVMC in running our simulation center, which has been shifted from the ground floor to the first floor as you. And he is instrumental in developing our simulation center. And this year he has been elected as the fellow of the South Asia prestigious academy of the Society for Simulation in Healthcare. And you'll be surprised to know he's the only one such person in Asia. He has written several chapters in books and also published several articles in journals. And I'm sure that his input on evidence-based simulation will be useful to all faculty and students, because with the increasing number of students and with patients becoming more proactive, and direct examination sometimes may be difficult with so many students. So simulation has a long way to go in the present training. And also the advantage is that you can keep on repeating till you acquire the skill, unlike a real life patient where the patient's interest also should be taken in mind. So I welcome you, Dr. Dinakar, from all our side, and back to the Dr. Deepa to continue the program.
Thank you, sir, for nice introduction and about the simulation. Now, I'd like to invite our speaker today. Before sir's speech, I have a few announcements. For the purpose of academic use, the program is being recorded. So I request all the participants to kindly mute yourself. And the recordings are available always in our AVMC YouTube channel, AVMC Puducherry channel. And hence, I request all to mute. And if you have any queries, it can be put up in the chat box. The queries will be taken at the end of the session. Sir, over to you, Dr. Dinkar, sir.
Thank
You'll be
you.
able to share your screen also.
Yeah, I'll do that. Yeah, thank you so much. So before I share my screen, I must thank AVMC for this honor to present in this webinar series. I have been following this webinar series with interest for a long time, and I can see that I'm following a lot of luminaries who have spoken on this webinar series. So it is indeed an honor for me to be here. And I would like to thank the Dean AVMC. I would like to thank Professor Vishnu Bhatt, who was my teacher as well in pediatrics when I was in JIPMA. I would like to thank Dr. Deepa, and above all, I would like to thank Mahalakshmi, who was my student when I was in JIPMA, for having given me such a difficult task and such a difficult topic to present. So with that, I will just share my screen. It's nice to see a lot of familiar names in the audience. So my hi to all of you who know me. So I'll be talking on evidence-based simulation. So before I start, why is it not moving? Okay. So just a quick overview of what is simulation. I'm not going to spend too much time on this, but just so that we can reach the topic of evidence-based simulation, it's nice to understand what simulation is. I'm sure all of you have now a reasonable working familiarity with simulation because, as Dr. Vishnu Bhatt pointed out, the NMC requires all medical colleges to have simulation. So there are many, many components of simulation which people don't realize. For most people, simulation means task training. When I say task training, it is something like passing a nasogastric tube or how to practice a urinary catheterization, or even a more complex tasks or skill like practicing CPR. But simulation goes way beyond that. And that is something that is important for us to understand. Simulation is also a very useful modality for team training. We all know that as healthcare workers, we work together in teams. Unfortunately, at no stage in our undergraduate or postgraduate career are we taught how to work together in teams. Simulation offers an ideal opportunity to teach our people not only how to work together in teams, but how to work in interdisciplinary teams where we have, say, nurses and nursing students, medical students, or postgraduate residents working along with maybe allied health professionals together as a team, so that when they work together, they come to understand the strengths and weaknesses of the other team members. And therefore, when they are in the real clinical environment, they will be able to do a much better job performing as a team. The other areas where simulation is useful is in process testing, also called translational simulation. Basically, what it means is whether the simulation carries over into the clinical area, and also if you want to test whether let's say your emergency department is working well, you can take a simulator into the emergency department and conduct an in situ simulation and see whether everything is working as it should. That may throw up some some basic problems, like for example, you may find that you're not able to get hold of a laryngoscope, or the laryngoscope light is not working, or the defibrillator is not charged or not available. So things like that can be done with simulation as well. Then, of course, another important component of simulation-based education is faculty training, and last but not the least, facilities development. Developing the simulation center and developing the other facilities within the hospital. So there are a
I
number.
found this on the web for facilities development. That means developing the simulation center in developing the other facilities within the hospital. Check it out.
What happened there?
I think some cross connection from your side.
I don't know whether inadvertently Siri opened out or something on my thing.
I think something like that.
Anyway, so sorry about that. So there are a number of educational theories underpinning simulation. And I won't go into the details of these theories because that is not the purpose of this talk. But the reason I'm presenting the theories as part of this talk is to say that there is a lot of evidence for these theories. And since these theories are underpinning simulation, it stands to reason that the same evidence that is supporting these theories in medical education also would therefore support simulation. So I will, as I said, I'm not going to go into the details of the theories, but we can leave that for another day discussion. Now, what are the principles of simulation-based education? So if you want to see in a nutshell, the important principles are curriculum integration. So simulation needs to be integrated into the curriculum. If you, otherwise it doesn't work. What happens is, you just by serendipity, you're doing simulation or but just by chance. So today I'm free, today some students are free. I take them into the simulation center and we conduct a simulation that, doesn't work very effectively. If you really want simulation to make a difference in your medical school, medical college, then it has to be incorporated into the curriculum. And there has to be time allocated for deliberate practice, where students practice repeatedly until they master a particular level of skill, and then they move on to the next level and the next level, and so on. There has to be obviously a rigorous measurement of the outcomes of simulation. Feedback and specifically debriefing is one of the most important components of simulation, and most of the learning takes place during debrief. Faculty staff preparation is important because simulation is a totally different kettle of fish compared to other modalities of medical education, whether it be lectures, whether it be small group teaching, etc. So it's necessary, therefore, to train faculty for this slightly different way of teaching. And it has been shown that without faculty development, simulation doesn't work so well. And above all, of course, all of us realize this, we need organizational support. Simulation can be expensive. To set up the simulation center, to get in the mannequins, to provide faculty time to run the simulations, and to provide means for the faculty to get trained in simulation, all this requires administrative and organizational support. A very important thing that has been described or noted as far as simulation is concerned is that it's got a dose-response relationship. In other words, the more number of times you do simulation interventions with the students, the better the learning. These principles have to be remembered, and if simulation fails at any time, it is mostly because we don't follow these principles. It was McGaggy, they did in as far as back as 2010, they did a review of all the articles that had come out relating to simulation-based education, and they came out with 12 best practices in simulation. And if you see, these are the 12 best practices. Again, I won't go into the details of this, but we follow these 12 best practices whenever we are running simulation. Now, before I go on to evidence-based simulation itself, which is the theme of the talk, let me talk a little bit about evidence-based medicine, because ultimately that is what led to evidence-based and other aspects like medical education. So what is evidence-based medicine? All of you have heard these buzzwords, and now everybody talks about evidence-based medicine. Essentially, it is medical practice that emphasizes looking at research, current research, and then applying the findings from those current research into your clinical practice. So in a nutshell, that is what evidence-based medicine is. So you look at the articles that are dealing with the subject or the patient that you are treating, look at the evidence for the various types of treatment, use that evidence in your clinical decision making. So if you look at the evidence-based medicine, there are many components for evidence-based medicine. So you have your own knowledge, experience, and skills. You cannot throw that out of the window. You cannot say everything is just based on evidence. We are all having certain knowledge and skill which we have learned and we have done through hard work and through our own experiences, and they stand for something. In addition, of course, nowadays we have to take patient viewpoint also into consideration. So their values, their viewpoint needs to be taken into consideration. Based upon these two, we decide a line of management after looking at the best available evidence, and then we come to a clinical decision. So this in a nutshell is what evidence-based medicine is. Okay. So these are the 5 steps for evidence-based medicine. So it's So it's converting information needs into answerable questions. So you are treating a patient with a disease. You first need to know what is, you need to get some questions out of that. What is the latest modality of treating this? What is the evidence for that? How do I treat this patient? If it's a rare disease, you may not even know what the problem is, how to diagnose the disease. So you get the information needs into answerable questions. Using those questions, then you find the best evidence to answer those questions. Then look at the evidence critically, because there are a lot of useless articles out there which are not validated and which are of poor quality. So we need to be able to do a good assessment of the various articles and apply the results of those assessments to our clinical practice. And then that doesn't end there. Then we have to see whether the patient really improved, and over a period of time, whether this particular evidence stood withstood the trials of time by evaluating the performance. So this is the 5-step evidence-based medicine model. Now, based upon evidence-based medicine, we came to the concept of best evidence medical education, or BEME. And this is defined as, the implementation by teachers and educational bodies of methods and approaches based on best evidence available. So here also what it says is, if you are a medical teacher or you are a medical institution, you should look at the best evidence available for any teaching modality and apply that evidence and then decide to use that teaching modality. And this definition came as far back as 1999 by Harden. However, there is a difference between evidence-based medicine and best evidence medical education. And the major difference is that we do not have articles of that degree of, rigorous, peer review or quality as we have for clinical medicine. And the reason for that,
You got muted. He got disconnected.
But his slide is visible, sir. Some internet problem in his.
no, is it coming through the computer or through the phone? Can you hear me?
Sir, now we are able to hear you in the meeting also, sir. You please go
Okay,
ahead.
right. Okay, right.
There was some internet glitch.
Okay, right. Thank you.
Your slide is not visible. Can you please?
Yeah, I need to maximize my screen. I'm just looking at how to do that.
Okay.
Just give me a second. Full screen is really small. I have to figure out how to reshare my screen.
Maybe
Sorry.
you can open the
You
slide.
can stop sharing and once again you share, sir.
The problem is I'm not seeing the sharing menu. Normally it pops up when I take the speaker to my cursor to the top. That's not happening.
Sir, here it is always in the bottom, sir. It won't be at the top, sir, in Cisco.
Okay.
Mute, stop video, share, everything will be at the bottom only, sir.
Okay, it shows that I'm still sharing. I'll stop sharing
Yes.
and I'll start again.
Now you have stopped sharing, sir. We are not able
Yeah,
to
I'll
see.
restart. Sorry, apologies for this.
Sir, it's okay.
Okay, can you see my screen?
Yeah, now it's okay.
Okay, right.
Yes, sir. Please
Yeah,
go
sorry
on.
about that. So basically, what I was saying was that there is an issue with using evidence in medical education, because in medical education, unlike in clinical medicine, the research papers are not as rigorous as they are in clinical medicine. Most of the research that happens in clinical medicine is quantitative research, where there are tested and time tested and proven methods which can tell you whether a particular intervention works properly or not, like randomized controlled trials, etc. Whereas most of the research that takes place on the educational front is qualitative research, which was where there's a certain amount of element of subjectivity. But of course, with the time now, qualitative research has advanced to a level where it becomes almost as rigorous as the quantitative methods, and it is an accepted method of research. But having said that, if you look at it, there are few systematic reviews or collection of evidence in medical education, and very few studies are based on randomized controlled trials, which is the gold standard for quality of research. And so, because of this, a new term was coined, which is BEAME, which means best evidence available in medical education. So what they are saying is, don't follow best evidence medical education, but look at the best evidence that is available in medical education, because the evidence that is available may not be of the same value or the same rigor as it is in clinical medicine. And the same problem happens with simulation as well. So that is with that proviso, let us move on to simulation based. So what are the challenges in simulation research? So we have seen that there are challenges. What are these challenges? So one of the issues is that simulation, normally people work together in interdisciplinary teams. So you have some nurses, you have some doctors, you have some allied health people, and so they are a heterogeneous group. And the outcomes also are not governed by the facilitator. So I am hoping that the students will manage a patient with myocardial infarction, but the student misdiagnoses is, I don't know, tension pneumothorax and goes totally on the wrong track. So the outcomes will depend on the participant rather than on the facilitator. We expect him to catheterize, but he does something wrong and he doesn't do it properly. So it's the participant who determines the outcome. And so because of these things, there is an issue in the research as well, because they're not standardized outcomes. There is often no control group, which I already talked about. And you can't, when you say that this particular intervention is helping the students, it's difficult to pin down the actual factor that is contributing to the patient outcomes. Was it the student's education that helped the patient outcome, or was it the training that he got in the ward, or some experience that he got with real patients that you don't know about? So all these issues are there. And most of the studies are single institution studies, which makes it difficult to make general conclusions. And of course, we know that simulation, etc., takes time. So time and resources, and we all know it's expensive. So these also act as a barrier. So how do we measure effectiveness in medical of educational intervention? So Belfield was the one who sort of defined the key criteria on basis of which we can measure effectiveness of medical education. And I will be talking about the evidence for simulation-based education using these criteria. So what are the criteria? First and foremost is just participation or completion by the student. So the student has gone through his 5-year MBBS program, or he has completed the upper limb module. Hello? Am I audible?
Yes, sir. There is somebody who have unmuted. I'll mute them.
Right. Thank you. So first and the very basic step is just the fact that the student participates or completes that particular course, which is not very, it's a very crude. The next is reaction or satisfaction of participants. So we get the feedback from the participants at the end of the course, and they say, yeah, it was a very great course, excellent feedback you get. So that is the second step. So this almost mirrors the Kirkpatrick levels. Next is whether they've actually gained any knowledge or not during that course. So any learning or knowledge that they got. Then whether that knowledge or learning that they did helped to change their behavior in the clinical workplace or change their practice in any way. So this is the next higher level, and the highest level of all, of course, are healthcare outcomes of that entire institution better as a result of that particular training. So these are all the measures of effectiveness in medical education, and I will be talking about simulation-based education on these measures of effectiveness. So if you look at overall, this is an older paper, but I think it reflects more or less what's going on even now. If you see the research in medical education, somebody did a research where they picked out 305 papers, of which they found that the maximum number of papers dealt with the learning, and very less number of papers dealt with reaction or satisfaction, the higher end, that is performance or behavior, and healthcare outcomes only 1.6. We have muted, please. Dr.
Yes, sir.
Shiva.
Shiva, please mute Dr. Srirang Yanpati.
Why don't you mute everyone?
Yeah, ma'am, I'm trying to do it.
I don't know, am I the host?
No, sir. We have the host, sir. You are the presenter.
Okay.
Trying to do it.
So anyways, so if you see the number of articles that are dealing with the topmost level rung of evidence in healthcare education, that is healthcare outcomes, only 1.6% of articles dealt with that. Most of them are dealt with the acquisition of knowledge, that is learning, knowledge or skill, whichever it may be. And but the higher level of learning, of change in behavior, etc., was not addressed satisfactorily. So if we go one by one into these areas, the first is just the reaction of or satisfaction of participants or completion of the course. So this, we all agree, is of little value in assessing outcomes, because just the fact that they have completed the course may not necessarily mean that they have learned anything. It may be because of compulsion to complete the course. Sometimes they may have liked you as a teacher or whatever it is, and they completed the course, but we can't assess learning on the basis of that. It is useful for short courses to use feedback to change the course design. So, you can get the students have completed the course or how many have not completed the course. You can find out why they didn't complete, and therefore you can change the course design. But it's very, very crude method of assessment. The next level up is learning or knowledge. So do they actually gain any knowledge or skill in this by using simulation? So again, in 1999, Harden showed a very weak linkage between performance in examinations and change in practice. And I think a lot of it was because our examination, we all know this, our examination pattern is different from the way we practice medicine. So anybody who's doing extremely well in the examination does not necessarily become a good clinician. And the other way is also true. People who do not do well in the examination may become excellent clinicians later on. That we have to blame ourselves as medical educationists, because we are not orienting our examinations to the actual practice. But I'm happy to say that simulation is different in this respect, because we try to make students practice simulation just as they would in real life in a real patient encounter. And the more realistic we can make it, the more lessons they learn. And this is the article by McGaggy, which shows that simulation-based medical education with deliberate practice is superior to traditional clinical medical education in achieving skill acquisition goals. So this is a very important paper that came out. And you can see over here that if you look at the favoring simulation-based medical education with deliberate practice, and on the left side is favoring traditional clinical education, you can see that this was a review article, and all the papers that they have quoted have shown a right shift in terms of the competence of or the learning that takes place for the students. So this is ample evidence to show that simulation-based medical education works. This is another paper which came out specifically on a complex task, which is ureterorhinoscopy for urology residents. And it found that students who were trained on simulation for ureterorhinoscopy had overall better scores in proficiency and less number of procedures in the clinical area they required to reach a particular level of proficiency. And they had, most importantly, they had less serious complications. So this shows that if you do simulation, the number of complications that you're going to cause in your clinical practice get reduced. And this is a very, very important and a very major lesson that we can get for emphasizing that simulation is needed. So coming to procedural skills training, another article on procedural skills training for central venous catheterization. So those who received simulation-based training, this was Barsuk et al., they showed that those receiving simulation-based training had fewer needle passes, arterial punctures, that means complications, catheter adjustments, and an overall higher success rate for catheter insertion. So we are all familiar with the see one, do one, teach one. In surgery, we say, you see one operation, you do one operation, you teach one operation. Unfortunately, this principle no longer holds true, and it has really gone out of the window And this is one article which has proven that this is not a good formula to follow now. So they found that students who had done the C1 teach one, C1 do one teach one traditional method of education, which were the higher year residents, did not do as well in lumbar puncture as compared to first year residents who were trained entirely on simulation. So the higher year residents were not trained on simulation, they were trained traditionally, and students who were trained on simulation did better in the clinical area compared to the more senior residents. So that is why now we should not be talking about the C1, do one, teach one principle at all. Now we come to the next level, which is healthcare behavior and practice. So we know that behavior change or performance improvement may not always affect outcomes. So this is an important thing that we must remember. But we have got now a number of articles which have shown how the outcomes in clinical setting have improved. So for example, teamwork and communication were improved during in situ trauma simulation program. So they ran a simulation program for trauma, and they found that the teamwork was better when they did the actual trauma care. Similarly, there was another article on trauma which showed that even a brief simulation exposure can improve teamwork. So it's not, though we say that simulation is best repeated again and again to get the best outcomes from simulation, this particular article showed that even one exposure to simulation can improve the performance of multidisciplinary trauma teams in clinical trauma settings. And here I would like to tell a story of my experience in Singapore exactly with the same thing. We found in the hospital where I was working that trauma care was not very good. And that was mainly because the teams that were working in the trauma, including the orthopedic surgeons, the general surgeons, the emergency medicine physicians, were not gelling, the nurses were not gelling together well as a team. So as a result, what we did was we ran a number of in situ simulations in the emergency department for complex trauma scenarios. And after a series of these trainings, we found that the trauma care improved tremendously because the people got to know each other. They got to work well with each other. And most importantly, they became friends with each other. They became familiar with each other. So there was no longer the shouting matches and slanging matches and all that. Why did you call me now? Why did you not call me earlier? Why did you call me so early? You know, stuff like that was not happening anymore. And as a result, the patient trauma care improved. So it shows that simulation for teamwork can definitely have better outcomes in the clinical area. And so they concluded that trauma teamwork training appears to be an educational method that can actually impact patient care. So next we come to the highest level, which is healthcare outcomes. So if you're looking at healthcare outcomes, we should understand that for translational medicine, they talk of 3 levels. One is the T1 level, which is results achieved in the educational laboratory, okay, which could be the simulation center, it could be the classroom, wherever it is. The next T2 level is patient care practices are improved. And the T3 translation level is improved public health and improved institutional outcomes as a whole. Okay. So one thing that we must understand, for everything that I'm showing you, there is also a flip side. So healthcare outcomes may not necessarily affect the quality of life indicators, because most of the educational interventions are on small scale, and there may be other confounding factors, as I said earlier, which might influence these outcomes. So there are a number of studies which have reported on the impact on patient outcomes, and they have shown that there is a reduction in complications for patients if students have been trained in those particular procedures. There is a reduced length of hospital stay for ICU, fewer blood transfusions, fewer ICU admissions, which obviously means that patients were treated much better. Improved quality of surgical care, reduced catheter-associated bloodstream infections, which is a T3 level outcome. That means the whole institution, there was a reduction in catheter-associated infections, which is a good thing as far as the institution is concerned. These are some of the criteria which also the the accrediting bodies look at to look for the quality of healthcare in the institution. And the next level, that is T4, where collateral, that is outside of the institution, because the students are trained better, because there are less adverse outcomes, because patients spend less time in the hospital, there is overall reduced healthcare cost, and there is a positive impact on the other trainees in the learning environment. So people want to come to your institution to learn more because they have seen these outcomes. And in fact, in the US, insurance companies have reduced the premium for doctors, especially obstetricians and gynecologists, who have undergone simulation training as opposed to those who have not. Which means if the insurance people are convinced that by going through simulation you can reduce adverse outcomes, I think that is ultimately the proof that simulation works. Because for money, insurance companies are very hard at it, and there is no way they will reduce premium lightly. So what is important is that outcomes are very, very robust. Simulation-based learning outcomes are robust, but they can decay over time, so they may require booster doses once in a while. It's just like any other skill that we practice. If we don't practice for a long time, it decays over time. So in once in a while, you need to give booster doses. And the classical example is in flight simulation. If you see, every 6 months, pilots are supposed to go to the simulator and go through a simulation training, even though they have been flying on a regular basis. And just today's news, I was reading about a Vistara captain who has been derostered and suspended because he assisted a co-pilot in landing the plane, but he had not undergone a simulation training to do so. So even though he was flying a real plane and they did the successful landing, the pilot was removed from his post because of this. So it shows how much importance the aviation sector is giving to simulation. So when we talk about patient outcomes in simulation-based education, this is another article which shows that simulation-based education was associated with the patient benefits in comparison with no intervention and non-simulation instruction. So if you see over here, again, there's a right shift for all the articles. This was a review article comprising of number of articles. And you see there's a right shift where that is favoring simulation as compared to not favoring simulation. So most of the articles have shown that simulation is better than no simulation. And this is another article. In the same article, they did also simulation versus non-simulation intervention. That is a traditional teaching. And you can see that most of the articles have given in favor of simulation. So this was Ajmi, who showed that simulation reduces door to needle time in stroke patients. So this is exactly what I mean by process testing. They found that the process in the institution improved because of simulation, thereby improving patient outcomes. So another example, in situ simulation training increased the rate of arrhythmia detection from 5% to 55%, which is a huge number. Practically a 10-fold increase in detection of arrhythmias in the emergency department through simulation training. And also the outcomes for cardiac arrest in hospital cardiac arrest were much better after they got, those who trained frequently in mock codes as compared to those who did not. So it's, you can see that there's a significant improvement in the patient care outcome. So we can no longer, sit by and say that we don't have evidence to say that simulation works. Okay, so what is the value of simulation? It is a chance to, of course, work, as I mentioned earlier, on team skills and improve learning in a controlled environment. So the thing is, you are in a controlled environment, you are not causing real patient harm, but at the same time, you are learning in a very realistic way, because the same distractions, practical difficulties, context can be brought into the simulation center. And those who have gone through a simulation process will understand the feeling is so real to them that they believe that they were actually dealing with a real patient. And so, you are whatever near misses or errors you make happen during simulated cases. So you're not harming real patients, and yet you get a learning opportunity. And as I mentioned earlier, also in situ simulation can improve team performance. And this emphasis is mine. Highlight the need for changes in the system. What do I mean by this? Let's look at one or two articles on that. So you see, for example, there was a study which looked at discrepancy of quality between many institutions. So they studied 30 hospitals. Some of these were specific general emergency department. Some of them were pediatric emergency departments in these hospitals. And they found that compared the deviations from best practice for hypoglycemic seizures was much more in the general emergency departments as compared to the pediatric specialty emergency departments. So simulation could actually look at a number of institutions and find out which institution was doing better in patient treatment by using simulation. This was not getting actual patient data. They used simulation and found the treatment was better in the hospitals that had specialized EDs. So the thing is, these events don't occur very frequently in real clinical scenarios. So if you try to get real patient data, you'll have to wait years and years to get enough data to be able to meaningfully analyze. but the simulation allowed this to be studied at a much more compact time course. And so you can use this to identify future readiness initiatives, whether the hospital is ready for, for these type of cases or not. So it can be used to streamline protocols and processes without involving patients. Again, my example in Singapore, we were moving to an entirely new hospital. And before we moved into the hospital, we ran code blue sessions in different areas of the hospital to see whether there was any issue in conducting a CPR or a resuscitation in those areas of the hospital. And in some areas, we found that it was very simple measure, like, the patient trolley was too high to do an effective CPR. So you just needed to provide a footstool. In certain other areas, it was more complex. For example, in the endoscopy suite, we found that the C-arm was interfering with proper approach to the patient for CPR. So the whole endoscopy suite had to be redesigned. But what is important is these measures, these things have to be done before you move into the hospital, or before you open up a new area of the hospital, or even to change an existing area of the hospital. You can do simulations to find out whether those changes will have any harmful impact or not. And you can use a simulated patient, that is, a real patient, standardized patient, or a mannequin to highlight the deficiencies in the workflow. So an important aspect of patient safety is something that we call latent safety threats. What do we mean by that? I don't know if you're familiar with the reasons Swiss cheese formula for industrial accidents that happen. So essentially what Reason said was that if you imagine a number of Swiss cheese slices stacked, stacked up side by side, these slices are all stacked up, and you know that Swiss cheese has got holes in it. So when you stack up these slices side by side, a hole in one of the slices may not correspond to a hole in the next slice. So therefore, these holes are latent errors. So these latent errors do not lead to an adverse outcome at the end, because the next slice that is there is stopping that, is not having a corresponding hole. So that is being blocked over there. But sometimes what happens is all the holes align, and as a result of it, you get an eventual adverse outcome. So now we are moving not only to look at the adverse outcomes and correcting those, but to correct the holes in individual slices so that the chance of an eventual adverse outcome is much less. And so these are known as latent safety threats. And there were two articles I have shown over here where they found that simulation training in pediatric emergency department identified latent safety threats. And in another study, they found very high 1.1 latent safety threats per scenario, suggesting that every single simulation had the opportunity to improve the quality of care. And I've seen the same experience with me. I was conducting a simulation training session in All India Institute of Medical Sciences, New Delhi. And this was with anesthesia residents. And what happened was, it was an anaphylaxis under anesthesia scenario. And we observed this mannequin is capable of drug recognition. So whenever they give a drug, we get on the computer, we can actually see what drug was given to the mannequin. So the endpoint for our scenario was for them to give epinephrine, because anaphylaxis, for them, that was the endpoint. We found that the students gave a very high dose of epinephrine, and the patient went into cardiac arrest and died. Later on, during the debriefing, when we asked them why they gave such a high dose of epinephrine, they said, no, sir, we never gave epinephrine, we gave ephedrine. In other words, they gave ephedrine thinking they were giving epinephrine because, they didn't bother to read the label properly. And this was an eye opener. This was a latent safety threat, which was an eye opener for the faculty there. And from that day onwards, they made it sure to make sure, that the epinephrine ampoules were kept separately. And they were also labeled with bright color so that everybody would know that this is actually epinephrine. So that's an example of simulation identifying latent safety threats. So what about the facilitators who teach simulation? Does it make a difference to the way they teach also? Yes, there are articles which show this. This is an article which looked at the effect of simulated learning environments on educators' self-efficacy to supervise students. And they found that there was very much improvement in the self-efficacy score in these participants compared to controls. And mainly in talking to students about supervision, adapting teaching styles for student needs. So you're changing your style according to the student's need, and identifying strategies for future practice. So simulation has been used not only to teach students a particular skill, but simulation can be used, in other words, to teach teachers educational skills. And that's an important concept that needs further exploration. So when we talk of faculty development, which is one of the main basic tenets of simulation, I said we need to have faculty development so that they can use simulation effectively. There is enough evidence to show that simulation faculty need training. And this is required now by standards of best practice. But the world over, simulation guidelines require it, and a lot of regulatory and accrediting bodies also will not accredit you if your faculty have not received official or recognized training in simulation. So a formal training process is needed, and also feedback is necessary. The faculty needs time for repetitive practice, and we need to provide them with whatever material they need to read up for doing the practice. But when you look at literature, there is a gap in the literature. We do not know how much practice is necessary for somebody to become efficient. We do know that practice is necessary, but we really need to do more work on how much practice is needed before we can say that they are proficient in teaching simulation. So now let me just go to the other side of the coin in terms of education for simulation. So there are, I already told you that randomized controlled trials for simulation. So they looked at emergency medicine randomized controlled trials, and they found that trials assessing simulation were only 1/4 of the total number of randomized controlled trials in emergency medicine, and their quality was not that clear, and therefore reproducing the interventions becomes challenging because of these reporting issues. So there is another article which looks at Kirkpatrick's evaluation of simulation and debriefing. Okay, it's a systematic review, and this came out in 2018, and it shows that there is a lack of studies at the highest levels of evaluation. I already pointed this out also in an earlier slide. So this is an area where future research is needed to show that actually it makes difference to institutional outcomes. So a lot of studies which have shown that simulation versus non-simulation instruction did not reach statistical significance, whether you use simulation or whether you use non-simulation instruction. A lot of errors for analysis were common, and validity evidence was infrequently reported. So they just use checklists, for example, which are not validated, etc. So all in all, if you want your simulation to be more effective, it needs to follow certain educational principles which I had highlighted in the beginning. And there are articles which show that simulation, if you do not follow the educational principles, it is not effective. So for example, one article said that after a single session of clinical medical students, there was no difference between simulation-based teaching and a lecture. And what they argue is that you need repetitive practice before they can learn properly using simulation. And another article which showed that structured debriefing definitely helps in improving learning. And this is a skill that it's more like an art form rather than a skill, and it requires a lot of practice by facilitators before they become good at debriefing, and then only learning can improve. So in conclusion, I would like to say that there is enough evidence to support the use of simulation-based education, and it is not just restricted to skill acquisition, but it also improves teamwork. It can be used, as I said, for process testing. It improves healthcare outcomes, and it has to be implemented correctly to be effective. So this is an article, McGaggy sums it up very nicely when he says that there's no doubt that simulation-based education technology works to achieve educational goals under the right conditions. That is coupled with deliberate practice and mastery learning, involving skillful faculty with curriculum integration and receiving healthcare system acceptance. So these are all provisos which need to be fulfilled if you want your simulation program to be successful. So the take home message, basically what I would like to give you is how to educate. The decision should not be, of course, should be based on available evidence, but you should also take into consideration other factors such as personal experience, judgment, skills, and learner values must be considered. And of course, your local situation has to be considered as well. But there's no denying that simulation is here to stay. And the sooner we adopt simulation, the better it is. So this is my last slide. And this is what I'm saying. So just seeing a shark fin does not necessarily provide the evidence that it is a shark. And unfortunately, most of our articles which are like this shark fin, which is just peeping out above the water, and we don't know what is the deeper one. So if you want to use evidence for any activity, including simulation-based education, make sure that that particular evidence is robust evidence. Thank you so much.
Thank you, Dr. Dinkar Pai. It was indeed a very nice and very informative, very clear-cut presentation. It was very clear-cut for all the faculties which you have presented. There is no wonder that simulation-based medical education has revolutionized the entire medical education. We are able to give a very good medical graduates in future thanks to the simulation lab. If it has been installed, it has been made possible in every medical college. We'll be able to provide a very good medical education with good medical graduates. However, there are some issues with evidence based education with respect to simulation, as you have pointed out that RCTs are very less. However, this can be overcome by qualitative research, which can be possible. And new terminology we got to know, like best evidence available in medical education, which you have mentioned, and the challenges in this context also. And also measure how to measure the effectiveness of a medical simulation also. Myself being a gynecologist, first I got to know about this simulation with the endoscopy. So one day when we use that endo trainer, next day when we come and do, our time for the surgery will be quite less. I myself have personally experienced that the time of the laparoscopy which we are performing, if we undergo the training of, so that's why we have, when I went for training, I was advised every weekly or weekly twice you should continuously keep on doing this. You should train yourself with endo trainer, and obviously it will decrease the complications, it will increase the confidence of the surgeons, and obviously this will result in a very good healthcare outcomes, and that's we are for. And to decrease the complication and to improve the quality of surgical care. And I was wondering about, you have told about, you have given an example of a detection of arrhythmias in the emergency medicine department because of simulation. It was really, I couldn't understand how much very good simulation they would have had. I haven't seen all those things, but still I was wondering about that. And identifying the latent safety threats, that regarding that how the simulation helps, still I have a gray area on that. But thanks to you, sir, we had a very basic knowledge and other things. And however, the outcome is robust and requires booster training, which you have mentioned, which I have also telling that I have been, which when I went for endoscopy training, our teachers were also telling the same. Thank you, sir. Thank you for such a very informative session. And if we have any queries, we will be able to take it. Dr. Vishnubat, sir, you have any queries and your input, sir?
Yeah, I think it was an interesting talk, as you rightly said. I think he is an expert, so no doubt he has put that all the points. He has raised one point that students did better with the simulation compared to traditional method of teaching. But I don't know whether they really had a full traditional method of teaching. But many times what happens is, I think we do not have enough patients, or you do not have enough manpower to train. Whereas skill-based training, of course, can be done after the regular classes, in between. So the exposure may be better. Do you think that they have compared the exposure in traditional method and simulation, and then looked at the outcome, or it is just
So this was a review article, sir, which looked at a number of papers which compared traditional teaching with simulation.
yeah.
So in this review article, when they summated all the findings from the various review articles, their conclusion was that simulation as a modality of education was better than traditional teaching. I don't believe they went into the reasons why simulation is better, but one of the reasons could be very well what you're mentioning, that simulation, and in fact, it is known in simulation circles that the reason why simulation is better is because it allows you this opportunity for deliberate practice. You can see that same condition again and again and again in the simulation center, whereas in the real life environment, if that particular patient doesn't come to you, you may not see that patient at all, and you have opportunity to practice as many number of times. So that could be one of the reasons why simulation is better. But the bottom line over here is that simulation is offering something more than traditional clinical practice.
Yeah. Second thing is about step debriefing, which you said. I think that is equally important when we do any simulation exercise, because sometimes it may not, they may not get a clear idea without debriefing. I think that is one of the important issues. And one major issue may be that emotional content of the training. See, simulators are available where you can communicate to some extent. But human communication will be definitely different from simulator communicating, because that will be standardized communication. Whereas how a human being or how a patient will behave, we cannot really predict sometimes. So that may be one of the shortcomings of relying only on simulation. What is your opinion?
Sir, I agree that definitely, I don't think anybody will argue that you should rely only on simulation as a training modality. But having said that, I want to make a distinction between standardized patients and simulated patients. The simulation community is now going away from the concept or the terminology of standardized patient, because as you rightly said, standardized patients give a standardized response in every encounter. Now that becomes important if you are doing it for evaluation, because you want the students to have a level playing field as far as evaluation is concerned. So standardized patients are important for evaluation. But now the way we train these patients to respond, we are calling them simulated patients. And a lot of them are patients who are really suffering from these chronic illnesses. So they do vary their responses to different students. And now we have trained actors who can even respond differently to different people, and we can introduce levels of difficulty in the student patient interaction. For example, there's one of my colleagues, Deborah Nestel. She's professor of surgical education at Monash University. They did a study where you start for IV, they strap the IV pad onto the arm of a standardized patient, and then we ask the student to just take the IV. So if you want to start an IV, you can just have the pad on the table and just tell the student, okay, this is how you do the IV, and then you make the student practice the IV until they get good at it. But that does not take into consideration the various nuances that happen in clinical medicine. Like you may have an agitated patient who is not willing to give, to allow you to start an IV, how you talk to the patient to convince him that you need an IV. So they did a study where they strapped this onto a standardized patient or an actor who simulated as a patient as a drug addict. And he refused to get the IV done. He was agitating, he was violent, and how the students tackled that situation. So you can definitely use simulation to mimic different types of patient encounters. You may not be able to mimic 100% of them because, as you said, you don't know what to expect in the clinical environment at any given time. But you can mimic many, based on past experience, such encounters to give students a more realistic experience.
I think Dr. Pushpa has got some questions.
No, sir, I just wanted to reinforce what Dr. Dinukar Pai was telling, that again and again practicing will reinforce the students' skill, and they become more confident when they work on in the real life. So that's how it helps. That's what I wanted to say, but he already told that.
Thank you, ma'am. Sir, we have query
One
from
question from
Dr. Kalsat, sir. We have an remarks from Dr. Shabna Parveen. She has this is such a informative talk. That's what she want to give her this one. And
Thank
we
you,
have
Doctor.
HOD emergency medicine, Dr. Kalsat sir, who heads the simulation lab. Anesthesia department or the medical education department or emergency medicine department or the surgical allied. Actually, I was also having this question. My query was like, why it has to be a simulation lab as such? Why can't it be in separate departments? That I was thinking. Why can't it be allied with the departments itself? Why it has to be in a instead of being in every departments? Why it has to be a single simulation labs? Whether it is
So,
a logistics or
if I can understand what you're asking, why can't each department have its own simulation? Is that what you're asking?
that is my question, sir. But Dr. Kalsat
Okay.
sir asked who
Yeah,
heads the
who heads the
simulation?
simulation? Yeah, okay, I get it. So this is a very tricky question. It's like asking who should be the leader of a code blue team or who should be the leader of a trauma team. Should be the anesthetist, should it be the surgeon, should it be the orthopedic surgeon? And it simply is, my answer to that would be the best person for the job. So in different institutions, you will find that different people are interested in simulation. What I would look at an ideal person to head a simulation center would be the one who is sold on simulation, who believes in the concept of simulation, who is willing to go willing to go the extra mile to make sure that simulation succeeds in that institution. It could be a surgeon, it could be an anesthesiologist or any clinical specialty. I know simulation centers which are headed by physiologists, for example. I know simulation centers which are headed by nurses, and they're very successful simulation centers. So I think more than the specialty or the background of the person, he should of course be trained in simulation pedagogy, but also he should be somebody who's sold on the concept of simulation and who's active and energetic enough to take simulation forward. So I'm sorry, I can't give you a very cut and dried answer to that, but it really, my answer to that would be it depends. And coming to your question, Dr. Deepa, these are two different models of simulation, if you like. If you see in India, most of the government setups, they have simulation equipment within departments. Whether you take like JIPMER, All India Institute and other places, traditionally, the department would purchase a simulator and they would use it for their own use. There are advantages to that. And the main advantage of that is that because it is within the department, it is close to your clinical work area, it's easier for you to access and run simulations over there. If you have a box trainer, an endo trainer within your department rather than somewhere far away, you are much more likely, whenever you have a time between cases, you can go and simply practice your endosurgery, laparoscopic surgery, etc. So that is a big advantage of having it within the department. The disadvantage of having it within the department is that it could be an equipment which is pretty expensive. Some of these simulators can cost up to 1 crore. And if you are using it, these are simulators that can be used across departments. Like some of these human-based simulators can be used by medicine, surgery, obs and gynae. So many departments can use them. So if you are only one department is having that simulator, then the problem is that such a costly piece of equipment is being underused. So in that situation, a centralized simulation facility would be better because then no department can claim ownership of that particular mannequin. So I feel the best thing is a hybrid model where some simulator equipment which is exclusively used by some departments can be there in the department, and other things which are used by many departments can be in the centralized facility. I hope that answers your question.
Yes, sir.
It will be
Thank you.
cost effective also, no, sir?
Sorry, sir. Sorry,
it will be cost effective.
Yes, it is cost effective because many people can use a catheterization model, for example. I would prefer to have it in the simulation center because so many departments teach it. But let's say an IUCD insertion model, I'll be happy for it to be in the gynae department because other people are not going to teach it.
Okay, so that's why NMC will also ask for a some skills lab in the department per se also, if we are going for a post-graduation.
We may not call it a skill lab, maybe some simulators in the departments for demonstration. Rather than having
it's like any other thing, right? You have seminar rooms in the department for departmental teaching. You also have lecture rooms for the whole institution where everybody collects together for any of the interdisciplinary talks.
Sir, I have other question. Like, suppose we have seen all the positive aspects of the simulation. For us, it looks like everyone gets confidence. So, suppose whether they'll be ready to face the complications if they keep on getting into the simulation. The person who is getting trained, sir, whether that is a disadvantage or whether it has been studied or not. Because till now, whichever evidence which you have told, it has reduced the complication, obviously. But whether they will be ready to suddenly, if a complication arises, they have been always seeing the positive side. So maybe we need a higher end of simulation models which can teach them that also.
So that's a very good question. So the simple answer is no. It will not help them to tackle unexpected complications if they have not been trained for those complications in the simulation center. But having said that, nowadays we are getting simulation solutions like virtual reality headsets, where like I'm working with a Chennai-based company which is making simulation for undergraduates. In fact, they've installed that particular thing in PIMS also. They've got set up a virtual reality simulation lab there. And in this, they are teaching, for example, catheterization. In the future modules, what they are going to do is they are going to bring in complications that happen during catheterization. So the student catheterizes and then the balloon, catheter gets stuck or the balloon ruptures or the blood from the urethra. All that can be modeled. It's only a software tweaking if you are doing it in the virtual reality environment. So you can recreate complications in the simulation center in order for the students to be better at managing those complications. But simulation cannot be a universal answer. You teach them how to do something properly. It's just like driving. a driving instructor can teach you how to drive properly, but whether suddenly an emergency happens and you have to really at that time you have to do something, you have to do that by your experience. So I suppose it's the same thing here.
Okay, sir. Thank you, sir. Thank you very much, sir. But sir, we don't have means we have other inputs like a very useful talk. We have appreciation from our participants. All have been very much. It was a really informative talk. That's a single word which I like to tell. Thank you, sir. Thank you so much for your time spending with us, giving us a very brief and very vital knowledge on simulation, because which is going to be our future of our medical education. We'll be expanding our simulation lab which we are having it, and all the faculty members and we have people from outside also who have joined with us, for faculty members also. Thank you, sir, for your time. Thank you very much. Thank you, sir.
Thank you for having me. Thank you.
Thank you, sir. I thank all the participants for this session. We have other appreciation chat box. The chat box is getting filled, sir. Thank you so much. I thank all the participants for attending this session. Meet you next Friday afternoon at 2:45 p.m. And another episode of 96th episode we'll be having next week. In another 3 episodes we'll be going towards the 100th one. Thank you so much. Thank you, sir. But sir, thank you, sir.
Thank you. Thank you. Thank you, Dinakar.
Pushpa ma'am, thank you, ma'am.
Thank you. Dr. Dinakar, it was really very crisp and focusing.
Thank you so much.